Good morning, good afternoon, good evening to everyone. Today we will talk about interventions at different levels. First, we'll introduce the concept of complex interventions. Then we'll go into different levels of interventions. And finally, we'll see some examples of different measurements. Let's begin with the concept of complex interventions. And the question is here, what makes an intervention complex? Complex interventions are interventions that contain several interacting components, not just one, frequently at different levels of action. For example, within the healthcare system, we can act at the patient level, the provider level, the organizational or system level. Complex interventions may approach more than one behavior as well. And there are some key characteristics that are typical of complex interventions and that we have to take into account. First, the different components of the intervention interact among each other. They are not isolated. Second, if well designed, the whole effect of the complex intervention will be greater than the sum of its components. And finally, you can measure the global, the total effect of the intervention, but you cannot disentangle the individual effect of each component. It's like a soup. You can say a soup tastes really good, but you cannot separate the contribution of each ingredient. So this takes us to the concept of embracing complexity in implementation science. And I really like this concept because in implementation science, we usually work with complex interventions, and as we have just seen, we work with interventions with multiple components, multiple levels and stakeholders, and also we even target multiple behaviors as well. But it's not only the intervention what is usually complex, we have other sources of complexity because the context is complex. We work in dynamic, multidimensional environments. And there is implementation complexity because we work with multiple strategies and different stakeholders, frequently with different values, interests, and motivations. Sometimes we have to deal with conflicting interests and incentives as well. And there is also a pathway complexity and different mechanisms of action for our interventions, including feedback loops, both positive and negative, mediators, moderators, etc. Finally, we usually work with complex populations, different groups of people with different characteristics and backgrounds. In implementation science, interventions are always nested within complex systems. Dr. Simon Cohn from Cambridge University defines a complex adaptive system as a dynamic and constantly emerging set of processes and objects that not only interact with each other, but come to be defined by those interactions. And there are some key attributes of these complex adaptive systems that are relevant in implementation science. These systems usually have blurred rather than rigid, structured boundaries. Actors' actions are based on different rules, motivations, and incentives. These systems are not isolated. On the contrary, they are embedded in other systems and co-evolve with them and are affected by them. And also, there is a degree of inherent non-linearity and unpredictability that we should be attentive to and that we should take into account, for example, to detect the need for adaptations. Well, let's talk now about different levels of intervention. We are already familiar with the social ecological model, which is a good starting point to understand the nature of the problem we want to address. We have to identify causes and factors, barriers, needs at different levels, and use this information to plan the different components of the intervention and the intervention strategies in each level as well. You can add more layers to the model and name them according to your particular project, context, etc. Let's see a hypothetical example. Suppose that we want to design a complex intervention to improve hypertension control. We may have identified different levels of intervention, and based on the results of our needs assessment, contextual analysis, and the evidence available in the literature, we plan the different components of the intervention. In this example, we plan components to be applied at the individual level, that is the patient, the hypertensive patient. Then we have the social interaction level with family, friends, co-workers, etc. Then we have the providers who provide health care to patients, primary care doctors, nurses, community health workers. Then we have the system level, that is the organization of primary care clinics, for example. We may also include hospitals, depending on the intervention. Then we have the community and neighborhoods where people live, and above that, the more macro environment of policies at the state, provincial, or national level. So these are the different levels. Now let's see some potential components of the intervention. At the individual level, suppose that we plan to provide counseling to patients about how to improve adherence to hypertensive medication, and also to, for example, counseling on healthy habits, such as healthy eating and physical activity. Then, at the next level, we'll incorporate peer support from a family member. So family members will have a role in the intervention. Then we have healthcare providers at the primary care clinics. We plan to train community health workers on how to give counseling to patients and use different tools to help patients to improve their habits, etc. At the organization or health system level, we'll develop an app, a mobile application linked to the appointment system, and we'll program reminders, SMS reminders of the appointments for patients. In the community, we will incorporate lay support networks in the neighborhood. At the municipality level, we will work with the local authorities to use the municipality social networks for a communicational awareness campaign. And finally, at the national policy level, we plan to conduct advocacy activities for laws and regulations on food labeling and salt reduction in processed foods. So, we have here a highly complex intervention with different components at different levels. Do we have to approach all the levels affecting the target condition always? Of course not. We have to define the level or levels where we will intervene and what strategies we will use in each level. Let me give you an example. In Argentina, we conducted a study in 9 districts or provinces in our country aimed at improving hypertension control in vulnerable populations. It was a complex intervention at 4 different levels. At the patient level, we provided individual counseling, self-blood pressure monitoring, and text messages on healthy habits and adherence to medication. We incorporated family members as part of the intervention as well. At the provider level, community health workers and primary care physicians received specific training, and primary care physicians received audit and feedback about their patients' blood pressure values as well. Finally, at the health system level, we created an electronic registry. The intervention did not include specific components at higher levels, but we were very much aware of key elements from those levels and aligned our intervention with them. For example, we took into account the availability of green spaces and public facilities in the neighborhood and incorporated that information during the counseling sessions. We kept informed about local initiatives related to chronic care in each province, and we considered free access to medication, which is a national policy in Argentina, of course, highly relevant to the project because our target population was poor, vulnerable population. Well, once we have all the different levels, intervention components, and implementation strategies, we have to measure our process and outcome indicators in each level. And here we have some examples. These are only examples. This is not an exhaustive list at all. For this example, I will use the RE-AIM framework. But of course, you can choose this framework or another evaluation framework and create your indicators according to your specific project. In the first column, you can see the components of the RE-AIM framework. And then we have examples of a quantitative approach and examples for a qualitative approach. In general, with quantitative indicators, we try to answer questions such as what happened and how did it happen. And with qualitative questions, we try to understand why did it happen and what influenced that happening. I have also added some examples of data collection methods for quantitative indicators, for example, study forms, medical records, local registries, and others. And in terms of the qualitative approach, in-depth interviews, focus groups, observations, etc. So let's see some specific examples. To measure reach from a quantitative point of view, we can calculate, for example, the number of people participating in the project, in the intervention, in relation to the number of people who was eligible to participate in the intervention. We can calculate the proportion of participants with certain characteristics as well. For example, gender distribution of our population in terms of gender, age, education, and other factors of interest. From a qualitative point of view, we can analyze factors and explore factors that influence participation in the total population and by certain characteristics as well. In terms of effectiveness, we can calculate, we can measure changes in health and other types of outcomes, both intended and unintended. And we can explore factors that influence on positive and negative outcomes. As per adoption, we can calculate the number of settings that got involved in the intervention, the number of providers that delivered, accepted the intervention, and we can explore reasons why providers or organizations adopted or not the intervention. What about implementation fidelity? We can calculate the proportion of delivery and adherence to each component and subcomponent of our intervention. The number of dropouts, for example, are also measures connected with implementation fidelity. And we can explore factors that allowed the intervention to go well or not well. We can explore barriers and factors that interfered and different adaptations that took place. In terms of maintenance, we can calculate the number of sites that continue the intervention past the study and the factors that affected continuation and or adaptations of the intervention past the study as well. Well, finally, I'd like to highlight that complexity is a feature of the system or systems and not only a characteristic of the interventions. And that in complex systems, there are different logics that coexist. We have the research logic with all its elements. This is a familiar place for all of us. But we have also a service logic. Healthcare providers and implementers have their own logic to do things. And we have the community member or patient logic and their reasons and motivations. And we have the logic of policies and politics working at an even broader landscape. In my view, one of our major challenges is to achieve an effective and trustful dialogue among all these different logics in the implementation field. Well, I'll stop here. During this talk, we have reviewed the concept of complex interventions, different levels of interventions, and some examples of measures at those levels. Thank you very much for your attention. I'm very much looking forward to sharing comments and reflections on these topics during our next plenary session. See you soon, and thank you.